Dr. Nilika Wijeratne is a chemical pathologist at Dorevitch Pathology in Melbourne, Australia. She's also an honorary chemical pathologist in Monash Health and an adjunct lecturer in the Department of Medicine in Monash University. Dr. Wijeratne is a member of the RCPA QAP Advisory Committee on Patient Report Comments and Multidisciplinary Working Party on Monoclonal Gammopathy. She's an RCPA College Examiner and NATA Assessor. So we're super happy to have her here with us today, and take it away. Thank you very much.
Thanks, Berlin and Sam. I thought that we would start with serum-free light chain, and if we have time, we will go through a few remaining topics of serum protein electrophoresis. During this presentation, I will go through the physiologic and clinical uses of serum-free light chains and the currently available analytical methods and some of the limitations of those methods. And finally, we will go through a few case studies. So, normal immunoglobulin molecule is composed of 2 identical heavy chains and 2 identical light chains, either kappa or lambda. So heavy chains are each paired with a single light chain via disulfide bonds, and to form a heavy light chain pair of or half of the molecule. 2 of these half molecules are linked by disulfide bonds in the hinge region to form a Y-shaped immunoglobulin molecule. Normal production of serum-free light chains is approximately 40% higher than of heavy chains to achieve correct assembly. Non-incorporated light chains are released into blood as serum-free light chains. So during the production, kappa to lambda ratio is roughly around 2:1. Kappa is normally monomeric and lambda is mostly dimeric. However, higher polymeric forms of both free light chains may occur in certain situations. So serum-free light chains are filtered by glomeruli and then reabsorbed and metabolized in proximal tubules. Although kappa-free light chain production rates are estimated to be twice that of lambda, their faster removal ensures that actual serum concentrations are approximately 50% lower than lambda. The serum concentrations of free light chains depend on the rate of production and rate of clearance. In patients with chronic kidney disease, kappa and lambda free light chain concentrations increase due to reduced renal clearance. When renal clearance is reduced, a greater proportion of free light chains are removed by cells of the reticular endothelial system. This mechanism removes both kappa and lambda free light chain at the same rate, so the relative free light chain concentrations change to reflect more closely the higher rate of kappa production. What are the clinical uses of measuring serum-free light chain? The serum-free light chain assay is a sensitive antibody-based system that can detect very low concentrations of monoclonal free light chains in the serum. Measurement of free light chain came into routine clinical labs in 2001, and use of the assay has grown since that time, as it has been shown to be an increasingly important complementary test, especially where standard electrophoresis or immunofixations are inadequate, such as in amyloidosis, non-secretory or oligosecretory multiple myelomas. The free light chain assay is now well established in the guidelines for diagnosis and monitoring of plasma cell disorders, as shown in this table. So I'm not going to discuss these individual criteria today, but it is important to note that there are a few different terms used in these guidelines. For example, we all aware of kappa lambda ratio. Some of the cutoffs are based on kappa lambda ratios, and you can also see they're talking about in-wall to un-in-wall serum free light chain ratio and difference in free light chains. I will go through those terms in a minute. An individual patient may or may not meet some of these criteria depending on the free light chain assay you use, and sometimes depending on the platform, even with the serum, even with the same reagent type. Most of these cutoffs stated in current guidelines are based on the binding site free light assay. Therefore, it is important to identify the characteristic of different assays to interpret results accurately. Free light chain measurement is also important in screening and monitoring of AL amyloidosis. So, what are the different terms used in these clinical guidelines? We normally report kappa and lambda free light chain concentrations and kappa lambda ratio on our reports. So in this example, as you can see, the kappa free light chain concentration is 5 milligram per liter, and lambda free light chain concentration is 250 milligram per liter. That gives you the kappa lambda ratio of 0.02, which is easy to calculate because it's just kappa concentration divided by lambda concentration. When the kappa lambda ratio usually indicates clonality. So in patients with multiple myeloma, we do see abnormal ratio due to monoclonal production of either kappa or lambda light chain. And this kappa lambda ratio is also used for assessment of response to treatment in multiple myeloma patients. What is in-wall free light chain? It is defined as the actual concentration of kappa free light chain in patients with monoclonal kappa plasma cells or serum concentration of lambda free light chains in patients with monoclonal lambda plasma cells. So in this usually indicates tumor load. In this particular example, you can see high lambda free light chain concentration. So we call lambda as the in-wall light chain in this example. So obviously kappa is the un-in-wall light chain. So when we calculate in-wall to un-in-wall serum free light chain ratio here is, you have to divide 250 by 5. So that ratio would be 50. And that's the ratio they included in multiple myeloma diagnosis guidelines as a malignancy defining criteria. So difference is usually the difference between in-wall free light chain concentration and un-in-wall free light chain concentration. For this example, it is kappa free light chain concentration, difference between lambda free concentration and kappa free concentration, which is 245 milligram per liter. How do we measure serum free light chains? Serum free light chains are measured using immunoassay. So at the moment, we have both nephelometric and turbidimetric techniques. In these assays, we use antibodies directed to free light chains only. So these anti-free light chain antibodies do not react with free light chain epitopes, when they bound to the heavy chain. They only react when epitopes are exposed as the free light chain. And there must be no cross-reaction with the intact immunoglobulins to get the accurate results. The first available assay for serum free light chain is binding site free light assay. Virtually all the studies on serum free light chains during reported between 2001 to 2010-11 were performed using the binding site free light assay. After that, we had Siemens in latex assay, and now there are a few other assays such as Serolite, CBA, and most recently Dasyme assay on Roche instruments. So some of these assays are turbidimetric and some are nephelometric, and depending on the instrument type, a free light chain could be either nephelometric or turbidimetric. Some of the characteristics of these assays are shown in this table, and this paper was in CCLM journal if anyone is interested. As you can see, these different assays use different reference intervals, and two of these assays use different reference intervals for patients with impaired renal function, whereas other two do not. So it is important to note these differences. Different methods use different antibodies to detect free light chains. Some use polyclonal antibodies and some use monoclonal antibodies. The assays with polyclonal antibodies can recognize multiple epitopes, and the monoclonal antibodies usually recognize a single epitope. Results reported in literature suggest that assays using polyclonal reagents detect a higher proportion of monoclonal free light chains. It has, on the other hand, also been suggested that assays using monoclonal reagents may perform better, especially in terms of assay reproducibility, which is important for patient monitoring. Because of these differences, we need to use specific reference intervals and cutoffs, and we can't use reference interval from one assay for a result from another assay. Although free light chain quantification provides notable improvements over previous methods in detecting monoclonal free light chain, it is a complex method and has its own problems. The fact that it is measuring heterogeneous molecule that differs in charge, amino acid composition, and size makes it vulnerable to issues with consistency, linearity, and antigen excess effect, and sometimes lot-to-lot variations. Polyclonal batches of anti-serum reagents subject to variation which can alter monoclonal free light chain reactivity. The results from different reagent lots could give different results. So it is important to verify the lot-to-lot variation before you change the lot numbers. Most of the time they are within acceptable range, but rarely we could see unacceptable differences between lot to lot. There is a possibility of antigen excess with accompanying underestimation of free light chain concentrations when the true concentration is extremely high. Sometimes it could occur at very low concentrations in some patients due to highly variable nature of the monoclonal free light chain. Most of the current methods and instruments has automated antigen excess detection techniques, but still you can miss some patients with antigen excess. So you have to suspect antigen excess if there is a high clinical suspicion, or if there's any discrepancy between free light chain, serum free light chain results and the electrophoresis results. Also, we could overestimate free light chain concentrations, sometimes due to interferences or sometimes due to reactivity to polymeric free light chains. Some monoclonal free light chains do not dilute in a linear manner. This is rare these days, and sometimes difficult to identify. It can be suspected when the free light chain concentration is inconsistent with electrophoretic findings or does not fit with the clinical context. Labs should adopt a consistent approach to sample dilution procedures for free light chain measurement and follow the manufacturer's recommendations or use a validated in-house dilution procedure. Sometimes for patient monitoring, you have to keep the same dilution for the same patient. You can't keep changing dilution factor for the same patient. Several studies highlighted a poor agreement between these different assays, especially in patients with multiple myeloma. The recent study published in CCLM journal in 2020, comparing the 4 currently available methods, showed overall good concordance for samples with free light chain ratios closer to the normal. As you can see, if we consider normal free light chain ratio, the concordance between different assays are not bad, they are pretty good. They use invol to uninvol ratio of 8. That's the cutoff used to define high risk people for progression, and 100 is used as myeloma defining event. That's why they use cutoff of 8 and 100. Based on this study, the concordances are substantially lower when we use the ratio of 8 and very poor with the cutoff of 100. So the same study looked at the method differences in absolute kappa and lambda free light chain concentrations and invol to uninvol ratios. These are the graphs, different plots for kappa free light chain concentrations. So as you can see, the comparison is good towards the lower end, but at high end, you can see a significant difference between methods. Same thing can be seen with lambda free light chain concentrations. Lower end is not bad, but at higher end, the difference is significant. These are the difference plots for invol to uninvol free light chain ratio. We can see a significant differences between 4 methods, especially for high results. So you can't use different methods to monitor patients. During the same study, they looked at few individual patients' results on 4 assays and compare that with the densitometric measurements. As you can see, these are 4 different patients. So the first one with kappa free light chain. As you can see, the kappa free light chain ratio could range from 319 on CBA assay to 1900 on Serolite assay. Similarly, this patient with lambda free light chain, the concentration could range from 690 to 12,400 on free light assay, and the electrophoresis densitometric measurement was around 5,300. So it is very clear that you can't use different methods to monitor patients. Another study published in 2018 in Clinical Biochemistry Journal highlighted the variation in free light chain results by instrument platform using the same free light reagent. So therefore, it is important to monitor patients using the same method and same laboratory to avoid method and platform to platform variation. It is also important to state the method clearly on your report, then at least clinicians could see the difference between methods. We will go through few case studies related to free light chain measurements. These are a few case studies from my lab. So we use free light immunoassay on OptiLight. This is a 50-year-old woman with, we didn't have any clinical notes as usual, but she had high CRP level, ESR, and anti-CCP antibody and abnormal liver function at the same time. Igg4 was normal. They have requested serum electrophoresis and immunofixation, and we haven't detected any monoclonal bands. These are the serum free light chain results. So both kappa and lambda free light chains are elevated with the normal kappa lambda ratio. So therefore, there's no indication of monoclonal light chain production. Both kappa and lambda increase with the normal kappa lambda ratio. As I said before, usually kappa lambda ratio indicates clonality. So we usually see this pattern in conditions with increased production, some autoimmune or inflammatory conditions, or sometimes in people with reduced renal excretion. But for this particular patient, Igg4 was normal, so it's unlikely to be due to renal impairment. Therefore, we included this comment on this report because she got a few inflammatory markers. So we don't know the clinical notes, but most probably the high kappa and lambda concentrations are due to either autoimmune condition or her liver problem or any other inflammatory disease. Next case is a 68-year-old patient. Again, no clinical notes. We didn't have any creatinine electrolyte measurements at the same time, or serum or urine protein electrophoresis. We got high kappa and lambda ratio with borderline high kappa lambda. We have high kappa and lambda concentration with borderline high kappa lambda ratio. So it could be due to autoimmune disease or any other condition which cause increased production, or it could be due to reduced excretion, which we don't know. We can't completely exclude monoclonal gammopathies because we don't have any other findings or clinical details. So because of that, we include this comment to cover all the possibilities. We said that borderline high kappa lambda ratio is not always indicative of a plasma cell disorder, but may occur when immunoglobulin synthesis is elevated or light chain excretion is reduced. And we suggested serum protein electrophoresis and repeat free light chain analysis in few months if clinically indicated. So the next patient is a 70-year-old person with normal serum and urine protein electrophoresis. Hemoglobin level was normal, but patient's Igg4 was 20 ml per minute. And this patient had high kappa free light chain concentration with normal lambda with borderline high kappa lambda ratio. So as I said before, we use free light immunoassay. So free light assay has separate reference interval for chronic kidney disease patients. Usually we quote the renal reference interval on all our reports as a comment because sometimes it's easy to quote that on all reports. So if we don't have that, maybe better to mention it in a report like that. Next patient is a 68-year-old patient. Clinical note says osteoporosis strain. Here we have high kappa free light chain concentration of 150 with low normal lambda free light chain and increased kappa lambda ratio. So that indicates clonal production of kappa free light chain. We don't know any other findings related to this person. So we usually comment these sort of report as this suggests monoclonal free light chain production, and we usually suggest protein electrophoresis with immunofixation if that hasn't been done already. And depending on the concentration and the ratio, we sometimes suggest urgent hematology referral. Next one is 65-year-old patient. Again, no clinical notes. This time, kappa free light chain is towards the low normal range, and lambda free light chain is elevated at 138 milligram per liter. The kappa lambda ratio of 0.04. Again, this indicates clonal light chain production, and it's good to do serum protein electrophoresis with immunofixation. This is 80-year-old patient, no clinical notes, or we didn't have any previous results for this patient. This was the first presentation to us, which is not uncommon, especially in Victoria, because sometimes we get treated myeloma patients once they discharge from our main myeloma centers. So as you can see, kappa free light chain concentration was 8 milligram per liter with very low lambda free light chain, and because of that, kappa lambda ratio is abnormal. But when free light chain concentrations are low, the significance of abnormal kappa lambda ratio is uncertain. We can't say it's due to monoclonal production because it could be. We commonly see this pattern in patients with treated myeloma, or sometimes in patients with immunosuppression. So usually, if we don't have any other information related to the patient with this sort of results, we would mention the uncertainty in the comment. It's always good to correlate with clinical findings and previous results in these patients. Next one is 89-year-old male. Initially, patient was in hospital when we got the first set of bloods back in 2018, April. We don't normally get any clinical notes from hospital patients. So, but around the same time, full blood count was unremarkable. EGFR 42, calcium was normal. This was the free light chain results. We had very high lambda free light chain concentration with normal kappa, which gave us a kappa lambda ratio of less than 0.01. If you calculate involved to uninvolved free light chain ratio for this person, that would be lambda concentration divided by kappa. That would be 159. So it's above the malignancy defining, myeloma defining criteria according to the guideline. And we have done serum protein electrophoresis at the same time, which showed monoclonal free lambda in the beta region and it was detected only by immunofixation. We suggested urine protein electrophoresis, but we never got that urine sample. And then we haven't seen this patient for a while, and after about 4 months, we had another set of bloods from a hematologist. And FBE, creatinine, calcium, protein electrophoresis, all similar to April results, but lambda free light chain concentration increased to around 4,000. And kappa lambda ratio is still really low, and enol to unenol free light chain ratio increased up to 267. No urine protein electrophoresis. Few days later, we had a phone call from this hematologist querying about our results. Apparently, they had another set of results from another lab in April, roughly around 2 weeks after the first set of results. And these are the results from the second lab. The second lab used in latex assay, and the lambda-free light chain concentration was 189 with them, with a ratio of 0.05. And because of that, he was querying the results, comparing our 2,289 and now our 4,000, saying it can't be correct. And fortunately, we had our samples, so we sent it to the second lab, and they got a result of 311. Again, even though it's very different to our results, the lambda free light chain concentration went up, and the enol to unenol free light chain ratio using in latex assay also increased from 18.9 to 25.9. So this example shows the importance of monitoring patients using a same assay. So basically, you can't compare results from pre-light assay with another assay. So that's what happened for this patient. Initially, patient had a lambda concentration of 2,000, and then 2 weeks later, 189, which clinician interpreted that it's improved or something like that. But that's not the case. It's just difference between two assays. And the other thing is the cutoffs stated in those guidelines are based on free light assays, so those may not be correct for other assays. I have included 3 case studies from this paper to show between method variations in some patients. This group have studied 85 samples from patients, and these samples were analyzed for serum free light chain using free light assay and in latex assays in order to compare the methods. Overall, they found from the patient screening, there was around 96% agreement between 2 assays. But they found 3 cases with interesting differences in free light chain results. So case number 1 was a 47-year-old woman who was referred to the orthopedic day surgery with bone pain. And X-ray showed osteolytic lesions within the pelvis, and patient had mild anemia, hypercalcemia, and but beta-2 microglobulin and creatinine were within reference interval. Serum protein electrophoresis was initially run on agarose gel system using hydrogel 30 gels, and total immunoglobulin concentrations were all within normal range. When they looked at serum free light chain concentrations on in latex assay and free light, as you can see, the levels are within normal range using the latex assay. And free light assay gave high lambda free light chains with abnormal ratio. but they didn't detect anything using low-res gel on electrophoresis. And then because of that discrepancy, they have repeated serum and urine protein electrophoresis using high resolution gel electrophoresis. As you can see here, there's a clear monoclonal band in urine as well as serum in the gamma region. So subsequent immunofixation identified these as lambda-free light chain. They have done bone marrow biopsy, which showed diffuse infiltration more than 90% of medium-sized plasmacytoid cells. So sometimes, unless you have a high degree of clinical suspicion, which should be the case for this patient because she had lytic lesion and then anemia and hypercalcemia, you could miss patients easily because initial electrophoresis was normal and one free light chain assay gave totally normal results. Second case, they described 34-year-old woman with a diagnosis of multiple myeloma, and this time referred for an annual follow-up bloods. Results including hemoglobin, calcium, creatinine, and nephrometric quantification of total immunoglobulin were all within normal range. Beta-2 microglobulin level was slightly high. And electrophoresis showed IgG lambda band in the gamma region, and there were no monoclonal protein in urine. Free light chain quantification using N-latex assay were within normal range, whereas using free light, they had very low kappa free light chain giving, with a normal lambda free light chain giving very abnormal kappa to lambda ratio. But this abnormal kappa lambda ratio is not due to an increase of lambda free light chain, but rather a result of suppression of kappa free light chain. The third case they described in this paper was a 59-year-old male who was referred to the outpatient department. The primary care physician ordered a few laboratory tests, including electrophoresis, and there was a monoclonal band in the beta-2 region, which, based on immunofixation, it was a monoclonal IgA lambda. Total immunoglobulin measurements were within normal range except total IgA. Serum free light chain quantification by N-latex assay showed normal results, whereas free light assay detected low kappa free light chain again, with increase in lambda and abnormal ratio. So this patient's bone marrow biopsy showed diffuse infiltration of medium-sized plasmacytoid cells as well. So even these three cases highlighted the differences between different assays. Sometimes you could miss significant results, like patients with myeloma, you could miss using one or two assays. Sometimes you could get abnormal results because of suppression in one light chain, not really due to monoclonal production of light chains. So what are the key messages related to serum-free light chain analysis? With the availability of few different assays, it's important to note that we can't directly compare results from different assays. It is very important to state your method on the report, especially if you have different labs with different methods in the city. Otherwise, clinicians just compare results from one lab with the results from another lab. Each assay has different reference intervals, so depending on the assay, you may need to use different reference intervals for kidney disease patients. An individual patient may or may not meet certain diagnostic, prognostic, or response criteria, depending again on the assay and platform use. That is mainly because current guidelines use serum free light chain cutoffs based on the free light assay. So further validations using other methods are required. It is important to follow manufacturers' recommendations to detect some of the analytical problems such as antigen excess and nonlinearity. And all assays will have limitations and may miss occasional patients. So you have to be careful when you interpret, and always it's good to compare free light chain results with clinical details if you have it, and protein electrophoresis results. So, Pauline, can we continue with protein electrophoresis, or do we have to stop?
We have about 20 minutes left. I think we can continue with the cases first, if you don't mind.
Okay, continue and then questions?
Yes, although we do have lots of questions already in the chat, but yes, please continue, and then maybe we can pull you back a few minutes.
Yeah.
Okay.
So this is leftovers from my previous presentation. I think I would go through some of the practical issues with measurement of monoclonal IgMs, and I will briefly go through heavy chain disease and IgG4 related disease and protein electrophoresis findings in IgG4. So accurate determination of monoclonal IgM concentrations is important to evaluate patients with Waldenström macroglobulinemia. We usually measure monoclonal IgMs using protein electrophoresis and densitometric assessment. We could also use total immunoglobulin measurements by immunochemical methods. But total IgM includes both polyclonal and monoclonal IgM and is usually higher than densitometric measurements. The overestimation is thought to be caused by accelerated immune complex formation due to the size and multimeric nature of IgM molecule. So again, if we use densitometric measurements to monitor patient, it would be good to use the same method for patient monitoring. What are the problems associated with IgM paraprotein? Sometimes it is hard to detect and quantitate monoclonal IgMs due to the nature of pentameric IgM molecule. Common problem is sometimes we can see a precipitation at the application point of the gel due to the highly polymerized IgM. They precipitate at the application point, and you can see a band across all 6 lanes. And sometimes aggregates of IgM monoclonal proteins may also interact with other immunoglobulins, leading to appearance of an apparent second monoclonal protein. And it is not very uncommon to get falsely low values due to pre-analytical cryoprecipitation. Can we identify and minimize these effects? Sometimes you can see a precipitate in the sample, or serum can be viscous or cloudy, especially when the sample is stored at 4 degrees. So if you see something like that, it is important to allow these refrigerated samples to reach room temperature or 37 degrees prior to analysis. Treatment of these samples with a reducing agent such as beta-mercaptoethanol or fluidyl or DTT could be useful to reduce these effects. These agents usually reduce the disulfide bonds and split the molecule into a form that is less likely to cause these problems. So this is an example of precipitation at the application point. This figure, you can see small bands across all 6 lanes. So it is very hard to identify the monoclonal protein here. So we treated this sample with BME and fluidyl, and after the treatment, this is the repeat phase, you can clearly see that band as IgM kappa. So you could also repeat the immunofixation if you don't have BME or something. You could also repeat the immunofixation replacing one of the antisera with buffer or saline. When the precipitate recurs at the origin, one is certain to be dealing with a spontaneously precipitating protein, usually a cryo, and then you can collect a proper sample for cryo. This is a patient with Waldenstrom macroglobulinemia. In this capillary zone electrophoresis, you can't see any obvious monoclonal bands, but when we measured the total IgM level, it was 13 grams per liter, which is high. So, and then we could clearly see IgM kappa band and another band in lambda using immunofixation. Because of that, we treated the sample with BME and repeated the capillary zone electrophoresis after treatment. Now you can clearly see the peak. So peak appeared after BME treatment. And this is the immunofixation after BME treatment. And still you can see the M kappa, and the lambda band is free lambda light chain. We use free lambda antisera to confirm that. The measured concentration using densitometric method was 10 grams per liter, which could be underestimated due to cryoprecipitate, or it could just be the difference between 2 methods. This is a patient with anemia, and they were querying monoclonal gammopathy on the request form. We can clearly see a monoclonal peak on the electrophoresis. Initial immunofixation showed monoclonal IgM kappa band and faint monoclonal IgM lambda band. I'm not sure if you can see the second M lambda band there. We measured serum free light chain at the same time, and the kappa concentration was 250 milligram per liter. And urine protein electrophoresis showed clear monoclonal free kappa light chain. Because of that, we repeated the immunofixation after BME treatment, and this is the immunofixation after BME. Now you can clearly see M kappa and another band in kappa which reacts with free kappa antisera. So initially we didn't have that second band, which was free kappa band. So we'll move on to heavy chain disease. What is heavy chain disease? Heavy chain disease is very rare. It's a rare lymphoproliferative disorder of plasma cells. First discovered in 1960s by Franklin. And it is characterized by production of incomplete monoclonal immunoglobulin heavy chains without associated light chains. So 3 types of heavy chains are recognized based on the class of immunoglobulin heavy chain produced. And these three diseases have their own characteristic features, which I would skip because otherwise we don't have time to complete it. So what are the features of protein electrophoresis in these patients with heavy chain disease? The frequency of finding a monoclonal band or spike on serum or urine protein electrophoresis is variable and differs among the three types of these heavy chain diseases. On immunofixation, the abnormal protein, if present, consists of a heavy chain, either G, A, or M, without an associated light chain. Alpha heavy chain disease, usually there may not be a distinct band or sharp peak on electrophoresis, presumably because of the tendency of these chains to form polymers of different sizes. In gamma heavy chain disease, we could sometimes the electrophoresis tracing, but it appears as broad and heterogeneous rather than showing a localized band. I haven't seen mu heavy chain disease so far, but according to the literature, they say pan-hypergammaglobulinemia is a prominent feature in mu heavy chain disease, and you could find a localized band in only around 40% of patients. So this is one of our patients. He was a known patient with Burkitt's lymphoma who was in remission for more than 10 years. Recently presented again with generalized severe lymphadenopathy. So this is the electrophoresis. The electrophoresis looked abnormal. And when we did the immunofixation, we found broadband with G antisera, but there's no associated free kappa or lambda. So this is a gamma heavy chain without light chain association. This is another patient, 81-year-old male, known patient with Waldenstrom macroglobulinemia. And you can see clear M kappa band, and also you can see broad G band without any light chain reactivity. So we did the immunosubtraction, and you can see the same thing with immunosubtraction. So this big peak is subtracted by anti-G antisera, but no subtraction in kappa or lambda. And the second peak is M and kappa, so it's a M kappa band. So this is a patient with monoclonal IgM kappa and gamma heavy chain. So next patient. This is 50-year-old male. We got a request for serum protein electrophoresis from a rheumatologist, and clinical notes mentioned as elevated immunoglobulins. So any thoughts on this one? Patient's total IgG level was 51.7, very high. And we can see a broad peak in beta gamma area. So, and in the peaks, you can see a broad staining in G, kappa, and lambda. So is this a monoclonal G band, maybe co-migrating G kappa and G lambda, or would you comment it as a polyclonal increase? So this is the immunosubtraction of this sample, and you can see the subtraction in G as well as kappa and lambda. So we didn't have a lot of other information regarding this patient, but we call this as a broad polyclonal peak in the beta gamma region, and we thought that it's likely to be due to increased IgG4 level, and we suggested measurement of IgG subclasses and clinical correlation. So what is IgG4 and what is the significance of measuring it? Immunoglobulin G is comprised of 4 subclasses, IgG1, 2, 3, and 4. Sometimes measurement of these subclasses are important in certain immunodeficiencies and few other conditions, specifically IgG4 related disease. And this IgG4 related disease is an increasingly recognized immune-mediated fibroinflammatory condition. It is relatively new. It was first described in 2001 and it can affect multiple organs. So clinical symptoms are dependent on the affected organ and sometimes it could be very non-specific. Some patients present with lymphadenopathy and sometimes it could be symptoms of asthma or allergy, or sometimes patients present with autoimmune pancreatitis. Diagnosis of IgG4 disease is based on clinical, radiological, histopathological features, but serum IgG4 level is also included in the diagnostic criteria. So you need to have either 2 or all 3 of these features to confirm the diagnosis. Management usually depends on disease characteristics. Corticosteroids are the usual first-line treatment option, and most patients respond initially well to therapy with corticosteroids, but relapses are common following discontinuation of the therapy. With the emergence of this IgG4 disease as a new clinical entity, correct interpretation of protein electrophoresis pattern is very important. As you can see in this first figure, IgG4 usually runs in the beta gamma region. So the position is important to suspect IgG4 bands. On one hand, for patients with non-specific symptoms and high total IgG, this characteristic focal band in beta gamma region may be the first indication that the patient's symptoms are related to IgG4 disease. On the other hand, because of this focal band may be misinterpreted as monoclonal band, this could be a trigger of unnecessary invasive tests and delay in correct diagnosis. Also, it is important to recognize monoclonal IgG4 band in patients with multiple myeloma. So this figure shows protein electrophoresis from a patient with IgG4 related disease. And this one is from a patient with IgG4 multiple myeloma. So you need to identify the difference between two. Sometimes it is important. It would be beneficial to measure IgG4 level if you have the assay in the lab. And back to our patients with elevated IgG4 level and broad peak. So this is before treatment. This was the one we reported as possible IgG4 disease, and we did the IgG4 level and it was 26.8, extremely high, and reference range is up to 0.86. And then they confirmed the diagnosis of IgG4 disease on this patient. I think they have done lymph node biopsy and few other tests, and they started treatment with corticosteroids. And we got another sample roughly after 5 months of starting steroids. And this is the serum protein electrophoresis after 5 months of treatment. And the broad peak disappeared and IgG4 level dropped to 6 grams per liter. We still get bloods from this patient and still it remains like that. But IgG4 concentration is still in between like 2 to 6 grams per liter. Okay, I think that's it. Just 1 hour.
Okay, wow. Thank you so much, Dr. Juratne, for for preparing all of that and the really very interesting sharing. We have many questions on the chat, so if you don't mind, I would just go in one by one. And as well, I would also allow mics for attendees now. So if you have additional questions, you can unmute yourself. So the first one, I'll just go through the questions as they appear in the chat. The first one was, can you please define lot-to-lot verification? I think you mentioned lot-to-lot variability in some of the free light chain assays. So how would you verify a new lot?
So as I mentioned before, we use free light assay. So when we get our new lot number reagent, we usually run patient samples. We used to keep batch of patient sample aliquots. We aliquots into several aliquots and we raise them to get the full range sometimes. And then because the problem is sometimes you see increase in results with one lot and next time it could be low or next time it could be further high. So we wanted to, at one stage, we wanted to see the difference over a long period. So because of that, we kept frozen aliquots to see what's the difference after a year or something like that. But if you can't do that, at least you have to, before you start the new lot number, you have to run patient samples, which you run on the current lot number with the new lot number. At the moment, we usually run around 20 patients with different concentrations, and manufacturer has their own criteria to as acceptability criteria. And here we have RCP QFP guideline on serum free light chain measurement, and in that guideline they accept 20% variation as acceptable limit. So I think binding side they have acceptance criteria as 15% or 20% roughly. So most of the time we get results within that limit, but very rarely we had one or two batches outside that range. So then we inform the manufacturer and we used to get different lots.
I see. Okay, thank you. So you would use patient samples as
yes,
to compare.
Yeah.
Great to know. So our next question is to ask for clarification again about the involved versus uninvolved free light chain. So you had one example where you had lambda was 250 and kappa was 5, and so lambda was the involved free light chain. So the question asked if it was the other way around, like kappa was 250 and lambda was 5, would then
kappa is the involved free light chain.
Right. So whichever free light chain is in the abnormally high range would be the involved.
Yes, it is easy before treatment. We had that discussion multiple times within our working group because especially some clinicians, they would like to have involved to uninvolved ratio reported on the report. But the difficulty with that, during first presentation, it is easy. Either it would be lambda or kappa in myeloma patients. But with treatment, that could change because after treatment, sometimes, say if the patient is lambda light chain myeloma patient, after treatment, sometimes towards the end, you could have suppressed lambda but slightly high kappa. Then if you use whichever the high value as involved, you would report it as, you would get kappa as involved at that stage, which is wrong. So that's the difficulty in lab point of view to report it on the report. Clinicians, they know what was the initial involved free light chain for that patient for monitoring purposes. So, but yes, at the time of diagnosis, if kappa is high and lambda is suppressed, kappa is the involved. But with treatment, in the lab, you can't be 100% certain unless you get all the previous results for that patient. But then I don't think you can build automated rules to calculate it, like calculating kappa lambda ratio.
I understand. So involved really means like the tumor, right? Which light chain
Yes.
is
So
the tumor producing?
if abnormal plasma cell clone produce kappa free light chains, that patient would have very high concentration of kappa. So kappa free light chain is the null light chain in that person. So similarly, if someone has monoclonal plasma cells producing lambda, lambda would be the null light chain for that person.
Understand. A follow-on question was the ratios of 8 and 100 that was mentioned in the paper. It says, could you explain why 8 and 100 were being analyzed there?
That is because, as I mentioned in my previous study, in the International Myeloma Working Group guideline for the diagnosis of monoclonal gammopathy, they have certain criteria as malignancy or myeloma defining criteria. So in that guideline, they use involved to uninvolved ratio of 100 as the myeloma defining criteria, but that 100 is established using free light assay. Because of that, the group who studied those patients used 100 to compare, and 8 is a cutoff described in one of those studies to assess the risk for progression of MGUS to multiple myeloma.
Great, thank you. We have some questions about your opinions of different assays. So there's first one is, what is your opinion on the N-latex assay on the Italica platform? Another one is, do you have any opinion on the BM prospect for free light chain measurement?
Sorry, I mean, N-latex assay it has been around for a long time compared to few of our newer assays, but personally, I don't have any experience on N-latex. I don't have any involvement with bindicide, but that's the assay we have in our lab. So
I see.
even though we have Italica platforms, we don't have Serum free light chain assay on that.
Right. So you don't have experience with those assays, so not able to comment.
Yes.
Okay. All right. Then the next question is, what is the cutoff? What's the EGFR cutoff to recommend the use of free light renal reference range?
It is bit. I'm not sure if they have any strict cutoff to use that, because there were several publications describing kappa lambda ratio at different point of EGFR. So sometimes in real life patients, we do see slightly elevated ratio without any monoclonal gammopathies. Even EGFR on 40, 50, 60 mark, but I'm not sure if free light manufacturers specifically say this is the cutoff you have to use. I'm not sure.
I see. So in the laboratory, do you report the renal reference range if
Yes, we
EGFR
do.
goes
We do
below?
have it as a standard comment on our reports. We mention the method and the platform, and then we have a second line saying with patients with renal failure, this is the renal reference interval for kappa lambda ratio.
I see. So, and you would do this comment like whenever renal function is below 60 or something? Or
No, that is a standard
personal?
comment, so it would
I
be
see.
on all reports.
Oh, so you put it on our reports. Okay, understand.
Because sometimes we may not get electrolytes and creatinine on the same episode, so we don't know.
Right, I understand. Okay, so this, the next question is an interesting scenario. Have you come across a patient with IgG lambda multiple myeloma? Serum free light chains were both low, but urine benjoids proteins show free kappa light chain. Oh, so lambda multiple myeloma with urine benjoids protein showing free kappa light chain, and serum free light chains were both low.
I can't recall any with those three criteria. No, can't remember.
Okay. That's all right. So I'll move on to the next one. Okay, another different presentation. If patient has a multiple myeloma, say IgM kappa, with significant peak on electrophoresis, but normal free light chain ratio with normal amount, kappa and lambda light chains in the normal range. What should we do next? Is there any analytical issue to consider?
No, not necessarily. If you have a heavy chain, monoclonal heavy chain, you could have normal free light chains on that patient. But if you have free light chain only on immunofixation with completely normal serum free light chain results, then you have to be careful. You may need to do further dilutions depending on your assay. It could be due to high dose hook effect or dilution issues. So if that's the case, you have to be careful. If you see a free light chain on electrophoresis, but with completely normal serum free light chains. We had few patients like that, which we detected significant bands on electrophoresis, free light chain bands with normal, initial normal serum free light chain results, which we had to do further dilutions.
I see. Due to antigen excess, there was a underestimation.
Yeah.
I see. Okay.
Usually the current automated detection systems are really good, but that doesn't exclude, like, sometimes you could have a rare patient which you miss with the automated antigen detection systems.
I see. But if you have a monoclonal intact immunoglobulin on the electrophoresis, it doesn't
We do
mean
see normal serum free light chain.
Okay. Next question is, how is mass spectrometry beneficial to overcome the different platform variation in free light chain estimation?
I think, I mean, mass spec results would be accurate, but I'm not sure what's the concordance between mass spec measurements. So once a lot of labs move on to mass spec, it's one thing we may need to look at. Even with the protein mass spec assays, they are describing differences between mass spec assays. So
Understand. It'll be yet another method that we'll have to now kind of validate and harmonize.
Yep.
Understand. All right. And last one. So, do you mind sharing on how is the reporting for the plasma, the electrophoresis result in patient with IgG4 disease?
IgG4, if we query IgG4, can you see my slides?
Yes.
So usually, I mean, we do have IgG subclass as in our lab. So if we get a patient like this, we always measure IgG4 level as a lab interest one before we comment on the electrophoresis. So if we get high IgG4 level, then we would include a comment like this: broad polyclonal peak in a beta gamma region likely due to increased IgG4. And usually before we issue the report, we discuss that with the clinician. to get more details about the clinical condition and just to make sure we are not misinterpreting monoclonal band as polyclonal, because sometimes it could be a bit hard to differentiate it completely. And one of the we have several patients with Igg4 disease, so for us it's not that uncommon. And one of the patients initially had electrophoresis reports from another lab as co-migrating IgG, kappa, and lambda, which is very hard to differentiate sometimes, because I mean sometimes it could be where it's like it's not broad as this one, and even the immunofixation one could easily misinterpret as co-migrating G kappa and G lambda. If you have the Igg4 measurement in the lab, that is one way to do, but some of the patients with Igg4 myeloma, you could have high Igg4 level if you use the subclass measurement. So always good to discuss the clinical situations with the clinicians. So if they have any query about myeloma, then they need to do further testing. Most of these patients, they have totally different clinical symptoms. So this patient, the main complaint was lymphadenopathy and autoimmune sort of reaction. So that's why patient presented to a rheumatologist. It's totally different clinical symptoms. So it is not a very easy sort of thing. You have to be careful when you comment on Igg4 related ones.
Yeah, very tricky.
Yes. You don't want to miss a big monoclonal band thinking it is Igg4 disease. So
Right, and even when you have like a kappa and lambda both strongly coming up.
yes, especially if someone has reported it as co-migrating G kappa and G lambda, and next time, if you are going to say it's a polyclonal peak,
Yeah, understand.
it's tricky.
Okay. Wow. So we've kept you way over time. I'm so sorry. But
Okay.
before we let Dr. Wijeratne go, anyone else has any last minute requests? Okay. No. So thank you so much for staying all this time and for preparing this interesting presentation. And thank you everyone in the audience for staying and asking such interesting questions as well. So I want to remind you about our feedback form. Please fill in our feedback form so that you can receive your certificate. And our webinar next month is on anemia. So join me again to thank Dr. Wijeratne for excellent presentation and for contributing to our community here. Thank you so much.
Thanks.